Thank you, Vineet. At the onset, I thank organizer for giving this opportunity. I'm Dr. Anup Toshniwal. I practice in Aurangabad, and today's topic, what I'm going to discuss, is use of immunotherapy in patients with poor performance status. So, I divided it into four parts: introduction, why this topic, there's some conflicting data, and what is the conclusion. So ICS have significantly improved outcomes, as we know, in other tumors as well, including melanoma, NSCLC, RCC. 40% of the patients with advanced cancers are now estimated to be eligible to receive ICIS as per the FDA treatment indications. However, most of these trials, they are done in good PS patients, and they do not present with this data is not representative of real world population. So there was a publication of immunotherapy management in special cancer patient population. This population included patients with poor PS, multiple comorbidities, autoimmune disorders, advanced stage, and SARS infection. So it was presented by Ramanarjan et al. In a review in JCO, and what they concluded in this retrospective analysis of the data was that in this population, what I mentioned recently, ICS are generally safe and effective. But there are other studies where ICA did not improve outcome in patient with poor PS. So there was some conflicting data, and so that's why another group had replied to that. And this is how actually this topic was came into this. That's what is happening with the ICIs in poor performance status patient. So in reply, what they mentioned that the data was very oversimplified, and they do not represent actually the full breadth of evidence. The author cited only one study in that paper for the role of PS and the outcomes of ICI. Also, limited population was included in the quoted paper where MSI was high, and it was not representative of the entire tumor population. And there are multiple other retrospective cohort studies where patients with PS2 or worse did far worse and had a shorter survival and poor response rate. Also, there is a lot of bias and confounding in the retrospective data, and we do not have reliable biomarkers as of now to predict which patient will improve with poor PS with these ICIs, and there was urgent need. So this is what basically was given in the reply. Also, there was issues regarding the cost of ICIs, because there are very, as we know, they are very costly affair to give ICIs in this kind of patient. And in planning ICS, what will happen is the focus will shift on treating the patient rather than planning end of life care, palliative care, and there will be also financial issues to the patient. Also, what we have seen in retrospect is that the chemo administration in the end of life setting or palliative setting is of low value practice, and it actually does not add anything meaningful in the long term to these patients. So that's what I summarized here. And then what happened is I looked at other data also, because these were the only two papers which were presented to me to present, but there were other data as well which is showing some conflicting data. So this is a paper by Rajvanath Veluswamy presenting this immunotherapy outcomes of pembrolizumab. This is a network analysis out of 640,468 patients. What they did is they projected the survival of patients with high PD-L1 expression with pembrolizumab and chemotherapy, pembrolizumab with chemotherapy and no treatment. So here actually, despite poor PS, patient who received only immunotherapy also had better as compared to no treatment, and patient with immunochemotherapy did much more better than single agent immunotherapy in PD-L1, 50% more of population, with median OS of 7.1 versus 2.7, and adjusted hazard ratio was 0.39. So there is obvious, this is the only paper where they had shown that despite poor PS, if PD-L expression is good, it might respond to immunotherapy and survival might improve. Then in 2023, there was another paper which was another analysis. Here what they showed is in poor patient with poor PS, despite giving IOs, the median overall survival remains low, that is 3.3 versus 13.4 months in patient with had good PS. This was basically Alberta immunotherapy database, and here despite patient receiving immunotherapy in the form of single dose of Pembro or Nivo, that still did worse if the PS is low. And this is the Kaplan-Meier's curve, which shows that the lower part of patient with poor PS did worse despite IOs. So there are obviously conflicting data in these scenarios. Now coming to Indian data, this is all international data. What is Indian data? We'll just see. And this is the paper by Vanitha Madam and Kumar Sir's group from TMH, and they had shown real world data of ICIs in solid tumors from India. And out of 9,610 patients seen in Tata Hospital, only 155 patients could receive immunotherapy. So this is the truth, what we face day to day in Indian scenario, that only roughly 1.5% of patients screened for these malignancies can actually take this. And mind this is data of all the tumors include NSCLCs, RCC, urothelial carcinomas, head and neck carcinomas. And in this analysis, what they found is the poor performance status at baseline was only the adverse prognostic factor for these patients. And this is the Kaplan-Meier's curve. The lower curves of PS2 to 4, they did worse as compared to patient with good PS. And in the discussion, they have mentioned that we are tempted to give immunotherapy due to relatively good safety profile in these patients with poor PS, but we do not have any randomized control data showing that there might be improvement in these patients, and we should decide this on case-to-case basis, especially when the affordability and accessibility to these drugs is very low in India. And I just wanted to highlight another study. It is also very relevant, not directly connected to ICIs, but to this setting of poor PS. This was an observational study, retrospective data of same Kumar Sir's group in TMH. And here what they did is from PS2 to 4, these patients were randomly given allotinib versus best supportive care. So patient who received TKI had a median survival of 3 months. Patient who did not only received best supportive care had only survival of 1 month. But this was unselected patients. If retrospectively they were checked for EGFR mutation, if they were EGFR mutant, then the survival jumped to 12 months versus the unselected 3 months. So here what I want to highlight is, if you can select out and tease out patients with driver mutations, these patients might more get benefited with targeted therapy rather than IOs. So this is the way forward. So we should look for reversible cause of poor PS, such as malnutrition like hypoglycemia, hypoalbuminemia, liver dysfunction, dehydration, dyselectronaemias. We commonly see hyponatremia in SIDH in SCLCs. So these are correctable causes of poor PS, severe pain, psychological issues, uncontrolled morbidities. And if the PS improves, we might step by step introduce drugs. We also require quicker NGS turnaround times so that we can select these patients with driver mutation so that we can give TKIs in time. We can use PCR ISCs to shorten the turnaround time, because NGS generally routinely in commercial practice, in the community practice, what it takes is around 21 to 28 days, but PCR and ISCs sometimes give us report in 5 to 7 days. Also, we can do liquid biopsies in some patients who are unfit to do a routine biopsy and have very high suspicions of lung cancer. And we can also try metronomic chemotherapy, especially in Indian setting where the ICI accessibility is very questionable. To conclude, ideally this setting requires a randomized controlled trial. There are a lot of issue and cost consideration since this patient have to further plan for end of life care, and in these patients, reversible cause contributing to worsening of PS, use of IV or oral metronomic chemotherapy, low dose immunotherapy as we are using in head and neck cancers, and precision therapy may be forward in this low poor PS group. And patient who stand to benefit should be offered a chance at therapy, while it is equally important that patient who may have other priorities besides life extension, such as time spent out of hospital at the end of life, have the opportunity to make an informed decision, and decision should be taken on case-to-case basis, and we should not be tempted to use IOs in this group of setting unless and until we have a very clear-cut discussion with the patient. Thank you.